you can be comfortably you can sit and listen to all these things at your house, at your only thing now the online offline has started. Then also always this, I feel that this online will stand. Okay. And thanks to Muralidhar Pai sir, Baswaraj sir, everybody are my friends only. All of them are, and many of them I am not seeing all the names, but thanks to all the KCOG managing committee members for inviting me. So so when KCOG is calling, there is not no for anybody, sir. It is always a prestige for all of us. Maybe as an youngster to get a talk in KCOG. So I myself, when it was called, and Bhiramat sir calling means there is no for it. Don't worry, sir. Anytime you call, even if it was a matter of 3 days only, you called. Then also I told that even my Thursday is my practice day, but I changed everything because I have to come for your talk.
Thank you.
So without any delay, so I asked sir one question before selected. I thought, see, something every time I talk on infertility and endoscopy and all, many times these are all very common. So I wanted something. I asked sir that who are the people who are listening to it. So sir told we have postgraduate as well as we have the consultants. So I have something like a mixture I have done. It is not a total postgraduate lecture or a. So there are points for postgraduate, and there are so much changes in cervix stages and staging and management. So I just thought something which will be beneficial for the postgraduates. It will be. So without delay, next the lecture is planned for 30-35 minutes, followed by some discussion. So you can share all your questions in the chat box, which Vidya Tobi madam will be asking me. So without any delay, we are starting. So my I have overview. See, I have divided like this. First, what are the changes that occurred in FIGO 2019? New update has come. Ca.Cervix, there is no change. 21. That doesn't have any change. Then I will tell you management of Ca.Cervix. I will divide it into clinical division. So you should understand. Divide it into an early stage Ca.Cervix. How do you manage? And a locally advanced carcinoma cervix, how do you manage? That is what. Then some role of brachytherapy. How do you follow up this case, and some complication radiotherapy, which a gynecologist we should understand. We start with FIGO. So if I want to tell you what are the changes that occurred, you have to know what are the changes with what was the original staging system in 2009. See, I will tell you for all the gynecologists sitting here, I will make it very simple. Stage 1 for any pelvic malignancy is confined to that organ. Okay, confined to that organ. Stage 2 means adjacent structures are involved. Stage 3 means pelvic side wall is involved. And stage 4, it comes out of the pelvis. I feel that all of you understood. Okay. So for the postgraduates, you remember any malignancy. It is a Ca.Cervix, endometrium, ovary. If you know this concept, it is very simple. Once more, I will tell you, confined to the organ. So for example, you take cervix, which today we are. Stage 1 cervix is confined to cervix. It can be divided into A and B depending upon A means it's microscopic, B means it's macroscopic. Finish. Stage 2 means it's the adjacent organ. What is the adjacent organ for cervix? There is only 2 adjacent organs. One is the vagina and parametrium. So stage 2, it is the involvement of vagina and parametrium. That is it. But it doesn't extend up to the pelvic side wall. Stage 3 means it's extending up to the pelvic side wall. Okay. And the lower part of vagina is involved. Lower third of vagina is involved. Stage 4, it comes out of the pelvis. So 4A may be bladder and bowel, and 4B, it comes out of the pelvis. This is the main division. Then what they did was that they're complicated. Previously, it was too complicated. That they told the depth of invasion as well as the lateral extension was so more than 7, less than 5, and all this for 5 to 7. Then it was more than 7. So this was a little confusing. So that lateral extension part they removed actually. We will come to it. I will show you. And certain, see, this 4 centimeter was also little. So it was very easily, they used to say BE is equal to B1 less than 4 centimeter, B2 more than 4 centimeter. But certain type is 2 centimeter in between was certain importance is there. That I will come to it. Then they will not mention anything about lymph node in the whole system. So in the stage 3, they started introducing the lymph node system. Then I will come to one by one. See, for all of us, we all know that Ca.Cervix, you ask in the postgraduate, Ca.Cervix is a clinical stage. Okay. So the question is, if you tell when I was a postgraduate and many years, if you tell CT scan and MRI in the staging, use for staging means you lose. They say that, oh, no. If ego does not allow MRI or CT scan. But later, when it came to the 2018 staging system, they started allowing the imaging system. Okay, imaging system as well as pathological assessment. Lymph nodes were taken, it was analyzed, and that pathological, you just have to mark it. I will come to it. Then what is happened with the stage 3 was that 3C, they include retroperitoneal lymph nodes in stage 3. Okay, this is what it was. So there was, but no recommended. See, revised staging system does not mandate the use of any specific technique. See, they don't say you have to use MRI, you have to use CT scan, does not say. They don't say that lymph node biopsy has to be taken, because see, India is a vast country, like world, there are the facilities at different places is different. Okay. Why we wanted all these things is to assess the size of the primary tumor and the lymph node status, which was missing, has to be included into it. Okay. So you have, see, you want to have imaging modalities. You have all these imaging modalities. So postgraduates were asked why CT scan, MRI, and all these things were included in the latest classification. So the first thing is that to measure the exact measurement of the primary tumor size. Second was the assessment of the extension. See, if you do an MRI, that parametrial extension, cervical extension, all these things can be clearly seen. Then the retroperitoneal lymph node involvement. So if they ask simple 1, 2, 3, assess the primary size, parametrium, that's the extension to surrounding, and to the lymph node assessment. But you should all think that non-availability of this tool should not delay the treatment. That is the most important in this. Okay. So, to summarize, best available technology should be used. Goal is to identify the most appropriate method. Why all these things were there? We all know that the dual therapy, to avoid dual therapy in the early stages, either you do surgery or you do radiotherapy. You mix together, the morbidity increases. Okay, now coming to, see, previously, some miscellaneous points were there. There were, I imagine when I was in a cancer hospital for fellowship, every Ca.Cervix case, we used to do cystoscopy. Maybe it was a learning process, okay, but unnecessary was there, most of the patients. So they used to say colposcopy, IVP, and IVP used to be done for all cases, cystoscopy, proctoscopy, X-ray, everything was there. Now it is very specific in 2018. Only if the patient has symptoms like proctoscopy and cystoscopy, if the patient is systematic, or it is a barrel-shaped endocervical growth or extension of the growth in the anterior vaginal wall, then only you do cystoscopy. Otherwise, you don't have to do. Then no longer other investigations are mandatory, but just that if it's a frank invasive cancer, you can do a chest X-ray, and if it's a late stage, stage 3, you can go for an IVP or a CT. IVP we don't do. If it is possible, CT urography is there, it is well and good. So these are other few points. Now let us see what is the staging system. All of you carefully see what changes has occurred. That lateral extension, you will not see that 7 millimeter extension part is not there. Okay, so you have only the depth is assessed. So in the stage 1A, only less than 5 millimeter. So the 1A means less than 3 millimeter, and 1A1 means less than 3, 1A2 means 3 to 5 millimeter. Finish. Very simple. When it goes to B, there is some importance in B. Previously, it was only B1, B2, B1 less than 4 centimeter, B2 more than 4 centimeter. By now, it is not like that. Why? Now it is less than 5 millimeter, no, more than 5 millimeter to less than 2 centimeter. Then the B2 is 2 to less than 4, and more than 4 is B3. So B3 is considered to be a bulky disease. When you come to management, B3 is not included in the initial management. It goes to the next level. Okay. So then coming to 2, see, A1, 2A is divided into A1 and A2. There also less than 4 centimeter, 4 than 4 centimeter is there. When you come to C, you can see 3A and B only was there. 3C was included to say that pelvic lymph nodes are involved. So pelvic lymph node C1, paraaortic C2, it is 3C2. So, and imaging, whenever imaging or pathology, whichever we use, kindly mention that what we have used. So why then it is a postgraduate question. When you go for an exam, definitely it will be asked, why this 2 centimeter? So it is then tumor less than 2 centimeter compared with those with tumor 2 to 4 centimeter with greater dimension. So they found that recurrence rate is more. So that is the reason why they divided less than 2 centimeter, 2 to 4 and more than 2 centimeter. Okay. Then one more thing which you should all know that in the exam that see in early stages, okay, we say that very early say fertility cancer, you put a corn biopsy. When you do a corn and if the margins are positive, even if it is less than 5 millimeter, if it comes, you upstage the disease and you say that stage 1B1, it make it stage 1B1. So small things. So in general, to whoever is listening, I don't want to confuse. Only thing what has changed is that lateral extension has been removed from stage 1A. Okay, lateral 1A. And when you come to stage B, there is something like it is divided into less than 2, 2 to 4 and more than 4. Okay, stage 2A is again divided into A1 and A2 less than 4 centimeter and more than 4. So which diseases you call bulky? 1B3 and 2A2 are called bulky disease. So we will keep it in your mind. I will come to it, then I will make you understand. Then you come to stage 3 where we have included the lymph node. And we told that imaging modalities can be used, freely used, and or the pathology can be also used. You take biopsy and pathology. Whatever we use, that has to be documented as imaging. These are the latest changes. So please, postgraduates, you have to know. Some things more is there as we go into the management. It's simple management, but you should, unless you know this, see LVSA, lymphovascular space invasion. It does not change the disease, but it has to be recorded. It is very important in the management. So LVSA is lymphovascular space invasion is a very important. Then another does not change is the extension to the uterine corpus. That also does not change the disease. Ovarian involvement also does not change the stage. Okay. Then very micro metastasis like 0.2 to 0.2 millimeter or isolated tumor cells you have found does not change the stage, but should be recorded. So whenever you are in a doubt, you assign a lower stage. That is the basic principle. So keeping in your mind, so does it mean that you have not included the later staging system? All these things can be included. So you have to remember LVSI, uterus corpus involvement, ovarian involvement, micrometastasis. 4 things has to be kept in mind when you go for the staging system. Okay. Now we have completed the first part that I was thinking that I will take 5 minutes for it. So you know, see, unless you know the staging system, how can you tell the stage-wise management? So now all the postgraduates and the consultants know what is the staging system and what changes that has occurred in the staging system. Now we come to the management part. So this is how I divided. See, this is for the consultant. That is why I called Hiramat sir and asked that it is for postgraduate or consultants. See, consultants have to be managed. See, they have to know. You want to do surgery, you have to refer to radiotherapy. Okay, radiotherapist. Okay, there are only 2 things they should be in their mind. So what we should manage, that as gynecologists, we should be managing our early stage cancers. That is 1A, 1A2, A1, A2, which you know, up to 5 millimeter depth. Okay, that is what we say. Then B1, B2. Here, please see B3 and 2A2 is here, but 2A1 is here. So B3, 1B3, that is why it is divided. 1B3 has moved away from the, so this is the most important thing. It is considered to be a bulky disease. The management is entirely different and the surgery does not come in it. So whenever you have, and all the postgraduates and the consultants, please see that don't go for dual modality of treatment. We will tell you why. We'll tell you. So first we start with early stage cancer. Okay. See, very simple. Early stage. Again, it can be divided. See, you saw that these are all early stage cancers. There I am dividing it that 1A and small 1B1 up to 1A means 1A1, A2 and small 1B1. Surgery is enough. You don't have to go. In case you are not able to do surgery, you can use, see, it should be there in your mind that it is not surgery alone. So you are not competent to do a proper surgery. You should refer to a radiotherapy. So radiotherapy also gives a complete cure. 1B1, B2 and 2A1. Okay, 1B1, B2 and 2A1. Okay, so here what is it is that surgery is done. Surgery can be done, or the patient can be sent for EBRT or ICRT. Even if you do surgery, there is a chance that you may have to add radiotherapy. Okay, this much all of you understood. We will come to it, how it is done. Now, this is the most important slide which I have made. If you listen, it is very simple. Stage 1A. Okay. 1A1, that is about 3 less than 3 millimeter, or some people say even 1 millimeter, less than 3 millimeter depth invasion is there, 1A1. So there are, now it is an early, see, you know that Ca.Cervix can be detected early. So if the patient is desiring fertility, imagine the patient is desiring fertility. You do a conization. Naturally, you do a conization. Here comes the most important part, LVSI. If LVSI is negative and you have done a conization, you don't have to worry. Just follow the patient. It is enough. Okay. If LVSI is positive, you have to go for a radical tracheolectomy. And one more thing you should all understand is that whenever LVSI is positive, you have to do pelvic lymphadenectomy. So the importance of LVSI for the postgraduates is that LVSI determines if the LVSI is positive, you cannot send the patient a follow-up. At least it's a fertility preserving. You have to complete to a radical tracheolectomy and lymphadenectomy. Okay. Imagine this early stage cancer, most of the time it comes here, completed, family completed. So it's a simple extrafacial type 1 radical hysterectomy you do, type 1 hysterectomy you do. There also, why you see for LVSI positive or negative is that LVSI negative type 1 is enough, but LVSI positive, you have to go for type 2 with lymphadenectomy. Okay, all of you understood this much? So this is about 1A1. Okay, 1A2. So it is now we have gone from 3 millimeter depth to 5 millimeter depth. Okay. Desiring fertility, you can do conization with close follow-up, or you have to go for radical tracheolectomy. But if she is completed directly, type 2 hysterectomy and pelvic lymphadenectomy has to be considered. Here LVSI does not. LVSI has value only in 1A1. Okay. 1A2, when it becomes more than 3 millimeter depth, it's there is no role. You have to either do a total conization or you can do a radical tracheolectomy. Family is completed, you should go for hysterectomy. So this is the first part, 1A. Now you have 1B1. Okay, 1B1. So less than 2 millimeter, that is 5 millimeter depth to less than 2 centimeter depth. Okay, 10 centimeter size of the tumor. Okay. Here, if the patient is desiring fertility, I told you, radical tracheolectomy can be done only up to when? Up to 1B1. Okay. So here radical tracheolectomy can be done. But if the family is completed, there is no role for radical tracheolectomy. You have to go for type 3 hysterectomy. I will tell you what is type 3 after some time. And pelvic lymph node dissection has to be done. Okay. Now listen, all of you listen. Now we come to B2. What is B2? 2 to 4 centimeter. Okay. And 2A1 is also less than 4 centimeter. Okay. It is less than 4 centimeter. No bulky disease. 2A1 only thing is that the upper part of vagina will be involved. Okay. Here there are two options. Okay. Here you can go for surgery. That is, if it is a young patient, because most of the time 1B2 and 2A1, even if you do surgery, there is high chance that you may land up in radiotherapy. Okay. That is why if you are a good competent surgeon, you go for surgery. Otherwise, you can send the patient for radiotherapy stat. Okay. And surgery, laparotomy versus minimally invasive. Now, present study, laparotomy is better. We come to it after some time. So, see, I'm not going to preventive or early pre-malignant lesions. I am telling the role of conization in early. So it is only role of conization I told you in 1A1. Okay. 1A1, then how do you do? You have to take the whole endocervix and ectocervix, the full cervical canal, the full transformation zone has to be removed. Okay. So it is an effective when there is no LVSI, no lymphovascular space invasion is there, it is the treatment of choice. If it is there, you may have to go for tracheolectomy or type 2 radical hysterectomy. Now, what is tracheolectomy? Just for a postgraduate stage, removal of the cervix along with the parametrial tissue. Okay, you can do it vaginally and you can perform it abdominally also. You can perform it laparoscopically, whatever way you want person. But laparoscopically, what we do is that you remove and then you remove either vaginally or that parametrial tissue with the cervix. And then what you do is that you put a cervical cerclage as well as you do pelvic lymphadenectomy. This is what a radical tracheolectomy, what it is shown here. You can see here. So it is a specimen of radical tracheolectomy, what I have shown you below. See, this is for a postgraduate, and everybody see, as a gynecologist, you should know whenever see the very young patient has come to you, she is only indication for radical tracheolectomy is only up to B1. 1A1, see here clearly, 1A1 with LVSI. If lymphovascular space invasion is not there, you don't have to do anything. All of you understood. If lymphovascular space invasion is not there, you have done a conization, the treatment is done. But whenever you have 1A1 with LVSI, 1A2 and 1B1, these are the people which you do radical tracheolectomy. Then if lesion is less than 2 centimeter, no evidence of metastasis, limited endocervical involvement, cervical length more than it has to be there, then only we can amputate. Post-conization, 4 to 6 weeks, only you will do. So all these things they will ask you in exam. You will do tracheolectomy when BMI less than 35, desire of future fertility, no evidence of impaired fertility. Please, postgraduates, at least take a photo of it, because they will be asking you, what are the indications for radical tracheolectomy? So you may not be asked how do you do, but you will be definitely asked, and this has to be done. At least for the consultant, they should know that up to 1B1, that is less than 2 centimeter size of the tumor, you can advise the patient for a radical tracheolectomy if she is very young. Now, this is the old classification. So I want something new things to be introduced. See, they used to say that type 1 radical, this is the PIVR classification. So for the PGs, they ask you, what is the PIVR's classification? Type 1 is an extrafacial, removal of all the cervical tissue is done. Type 2 is a modified radical hysterectomy, where medial to uterosacral, medial to cardinal ligaments, and medial to ureter. Everything is medial, that is type 2. Type 3, when it comes, that was the original, what is the Wertheim's hysterectomy that was told. There's a wide resection. You mobilize the ureter, remove the whole parametrium, cut the uterine artery from its origin, okay, and uterosacral and cardinal ligaments are cut from the origin. So that is what. Then you come to the ureter divided from the pubo-vesical ligament, and the superior vesical artery is ligated, and 2/3, it's a stage 4, and 5, it comes to the excentration part. We'll come to it. See, now you have to know the latest classification. That is what is called Coromora Classification. Nothing great is there. It's the same thing with some modifications are there. So everybody, it is divided into type A, type B, type C, and type D classification. Okay, all of you understood. Type A means a minimal resection of the Ca.Cervix. That is similar, same. So type A hysterectomy and type 1 radical hysterectomy is the same, extrafacial hysterectomy. Less than 10 millimeter of the vagina is resected. So it's the same. When it goes to type B, it's a transection of the Ca.Cervix, so the parametrium. Corresponds to type 2. There, two things are there, B2 and B2, B2 and B1. If you remove the lateral parametrial paracervical lymph nodes, we call it B2, and it's not removing, we call it B1. And here, more than 10 millimeter of the vagina is being resected. Okay. Type C, that is the common radical hysterectomy that is done. So what do you mean by type C is again given to C1, C2. Now it's a nerve sparing hysterectomy. See, hypogastric nerve is being spared. It's not a difficult. So if we identify and spare, if you are sparing it, C1, and if you are removing that also, we are not taking care of it, it's C2. Then comes a lateral extended wide resection. So we are mostly concerned about A, B, and C. So all of you listen to this. This is just to show that this is when you see the NCCN guidelines, you can clearly see here, you can see in NCCN guidelines what things are removed. This chart is available in the net, you can see, and I have compared it with all the hysterectomies, whichever type A, B, and C1, that is one compared. You can see here for the postgraduates or the normal people, see what is a total hysterectomy and what is a radical hysterectomy. Total means you go close to the uterus. Can I see this like this? So if you are taking like this, the parametrium out with lymph node, what we say it's a radical hysterectomy. In another cross section, you can see type 1 is this, type 2 medial to, type 2 medial to this. See here, and type 3 when it comes, it involves the parameter full, the lateral cardinal ligaments and the uterosacral ligaments are taken from its origin. Same thing, lymph nodes. So Coromora classification, lymph nodes are lymph nodes we say not the type. It's not ABCD. It's a level. Level 1 internal and external iliac. Level 2 common iliac and presacral nodes. Level 3 aortic. This is the inferior mesenteric artery. Aortic inframesenteric, and level 4 is aortic infrarenal. So this part is the level 4. Okay, level 4. This is level 3. Okay. Now we come to another very important controversy, root. See, all this controversy started when this LAC trial was introduced. So everybody should know what is a LAC trial. LAC trial, what they did, see, they took patients of 1A1, which is LVSA positive, I told you, 1A2 and 1B1, where we commonly do wartime cystectomy. So open radical hysterectomy and laparoscopic and robotic. So 312 and 320 patients were in each arm. So you come to the results now. So open approach, disease recurrence was low, disease free were better, progression free, and overall survival was better. Okay, all of you. Disease recurrence rate was higher rates, disease free poor rates, and progression poor rates and worse, everything. So more patients died juvenile. So this made into picture that this study changed the whole concept. Now, if we as postgraduates, if you are asked, I was started doing laparoscopic radical hysterectomy for cervical cancer, but I stopped because patients, if they ask, even if you want to do, you have to convince the patient that this is better, that then I am going to do laparoscopy. The patient tells you, otherwise you cannot do. But before LACC trial, we all were very happy as laparoscopic surgeons. We say lapros shows better short-term outcome, oncology outcome, and 5 years are well same. Laparoscopy was safe, low operative complication, and laparoscopic improved outcomes compared to, and disease recurrence rates are well, everything. So we were having comparable results, and we were telling. After LAC trial, we changed everything. Then also, as laparoscopic surgeons, we say that no study was able to find a difference of tumor less than 2 centimeters. And it may be they say that why this result came, because many surgeons who are doing not less radical laparoscopically than open surgery, incorrect manipulation what we use in laparoscopy, and spread carbon dioxide insufflation was causing the spread. So we started using, we avoided uterine manipulation. Then you close the vault from below. Then endobag for lymph node removal, and we used to put staplers down. The full vagina is to be closed, and then you cut open it and take it. So it is like a bag. The cervix was like a bag and taken it out. These are the latest things which were done. Whatever we do, okay. Yeah. Now, when you are asked what is the approach, it should be not laparoscopy. It should be laparotomy in your exam for the time being. Other studies are going on. It will take another 5 to 10 years to get the results. Then we may change. What sentinel lymph node? So there is one thing, new concept, sentinel lymph node. Sentinel lymph node has very big, vulval cancer, endometrial cancer, breast cancer. So what is the role in Ca.Cervix? Before telling what do you mean by sentinel lymph node, the first lymph node draining the lymphatic flow with the highest possibility of involvement is called a sentinel lymph node. Okay. According to this, what is the principle behind lymph node marking hypothesis? If that sentinel lymph node is negative, it rules out probability that the other lymph nodes will be. So what they do is that remove the sentinel lymph node laparoscopically or opening up. How do I will tell you? You can use different types. You can use a dye isosulfan blue. You can use a radioactive substance secretion 99 labeled albumin, or you can use indigo cyanine green ICG. Whatever you use, the results are the same. Okay. See, all these things are so this is a small video showing. I will show you fast. I will show you. So I will show you. This is what I am doing. We have a sentinel lymph node. This is I did it for an endometrial malignancy node. So just to show that we take this sentinel lymph node, it is this ICG, and we inject on both sides of the cervix. So 3 o'clock and 9 o'clock we inject 1 ml superficial deep. Then we go inside. We open up the spaces, paravesical, pararectal spaces are being opened up. Okay, so open up all the spaces. Then after some time, after opening up, we on the ICG mode. Okay, you can see this is the all these things are opened up. Just to, it's only 2-minute video. You can see all the by the time you have injected, it takes about 10-15 minutes. So by the time you open up, so you see the lymph node, you should see the whole draining into the lymph node. So I saw the lymph node. Now what we have to do is that now we have to dissect that lymph node and take it out. That is how we take it. So once you have taken, now we go to the other mode, dissect it out. So we understood that it is an obturator node. So sentinel lymph node on the right side was an obturator node. So this is the obturator nerve, you can see on the side. So the obturator node was dissected, taken it out. Obturator node was taken out, and once you take it, you can in between put the ICG mode. This is the previous system which I am having, stored system. Now the latest system in the live, when you are doing itself, you can see that blue color. So now you hold it up, take it slowly, you cut it and take it out and send it for the lack of time. So this is how it is being taken it out and send it. Now you cut it with I'm taking it with the harmonic, and anything is remaining, you can even see, you can see again, you can see and take it out. So this is how it is being taken out of. Okay. So how do you do? See, you can go inside, see that if it is there a sentinel lymph node on one side only, the other side you have to remove the whole nodes. Okay. And if there is some enlarged node, you have to remove. And it is not an easy thing. This sentinel lymph node is not an easy thing. All of you should understand. Okay. See, sentinel lymph node, if you are able to stain with our normal stain, immediately you will get the result. If you are not able to stain with it, you have to go for ultra staining technique. That is not possible in a frozen session. So you may have to take time. So how useful it is, and for the time being, students, you don't answer in cervix. Cervix is only under study purpose only. So these are just to know that. I want audience to know that such a concept is there. What is sentinel lymph node and how do you do it, and what is the concept behind it? That is what. So don't depend it on too much. In endometrium, it's okay. Now, in the early stages itself, what is the role? As I told you, you can go for radiotherapy also. There is not much difference in survival, 5-year survival rate if you are going for radiotherapy. But preferably young patients, we go for surgery. The complication of radiotherapy is more. That is why. But doing a substandard surgery is more. See, nowadays what happens is that I want to advise, see, don't take it personally, all the juniors laparoscopic surgeons in Karnataka. See, I know many people who come out, they have not trained in any oncology institute, and but they have not seen a Wertheim's hysterectomy. They go back, see some YouTube videos and start doing. So the initial years, see, the cancer patients are not the patients to study. You are doing something crime here. So you don't do a proper surgery. The same thing, you don't have, imagine you don't have any oncosurgeon in your city or a village. You send to a radiotherapy, it is free. Early stage also radiotherapy, it can be cured. So that is ideally, there is no ego or nothing. So you have, this is a small advice to all of you. You want to do a oncology surgery, please go and get trained. You have in Karnataka, it is nothing. You can go to that is in Kidwai, not Kidwai itself. So in Karnataka, you have you can go there. You can be trained under many people, Uma Madam, Bafna sir, and all. You go and see there, watch the surgeries, at least open surgeries. Then you come back and do your laparoscopic surgery. That is what I want. And Ca.Cervix, role of laparoscopy, don't do now, please. It is, if there a case or something comes in court, you will not be able to stand. Okay. These are surgery versus radiotherapy, everything almost the same. Even if in late stages, like say 1B and all, even if you do surgery, you may have to go radiotherapy. So they say that radiotherapy alone, maybe there is 46% reduction in the recurrence, favoring radiotherapy arm, even if you have done. So radiotherapy can be given even in 1B1, even if you have done a surgery, you can. So they compared it, and there are other studies also opposite. They say that there is not much difference if you give radiotherapy. But ideally, I feel that radiotherapy has to be substantiated whenever you are going in the early stage, but you are going little advanced on early stage. Okay. Now you come to the locally advanced stage. Locally advanced stage, you can see here 1B3 and 2A2. So locally advanced stage can be divided into two. Okay, first I will tell you what we call as a bulky disease. Whenever that concept of radiotherapy alone has gone in all the stages. So here we come to we are coming to the last part of it. Here we come to something called CCRT. CCRT is concurrent chemoradiation. That is what? So 1B2 locally advanced cervical cancer. See, 1B2 onwards, 1B3 and 2A2, then 3-4. Okay. So 1B3 and 2A2, when you take it separately, these are called the bulky disease. Surgery is not there. Okay. It is concurrent chemoradiation or exam. But there is something called a concept of neoadjuvant chemotherapy have come. You have an excellent study from Tata Memorial Hospital also. It has only in the experimental stage. Until now, it has not shown proper. So they say that neoadjuvant chemotherapy you give and then do radical hysterectomy. So it is not up to. So at least you know that such a concept is there if somebody asks you. So so what is this concurrent chemoradiation? See, what is the basic thing is that includes chemotherapy, external BB radiation, and endocavitary brachytherapy. Ideally, everything should finish between a span of 5 to 6 weeks. Okay, so everything together, it is done. Total about 80 guys what you have to give radiotherapy. EBRT you give about 45 to 50, and rest 30 you give by intracavitary. 80, 50, and 30 you remember. So you have to, so 80 to 90 is the total amount, including EBRT and ICRT, intracavitary radiotherapy, that has to be given, or brachytherapy, we call it other. So teletherapy and brachytherapy are the other names. So EBRT and brachytherapy should be completed within 8 weeks. So what we do is that on Monday we give cisplatin, start the radiotherapy, give for 5 days, Saturday, Sunday off. It is not that the consultant is going home. It is to recover. See, cells has to recover. The hemoglobin has to recover. Cells, as you all know, that it's basically the oxygen. So hemoglobin should be there proper. So the basic concept you should understand. So 2 days, 5 days. So like it is the 5 weeks it is given. So it is given as 25 fractions. Okay. 50 guy is given as 25 fractions. I will show you the different protocols and different. See, this is for everybody to learn. See, why you have started, olden days only radiotherapy was there. So why this new concept of chemotherapy has been added to radiotherapy? See, used it organ preserving intent. See, when you talk to a radiotherapist, they use a word OAR, OAR. What is it, OAR? Organ at risk. What are the organs at risk? It is the bladder, rectum, and colon are the organs at risk. So their function and all these things has to be compromised. So that is why you can decrease the dose of radiotherapy. Second is that chemotherapy is a radiosensitizer. So what is called, it's a local control, and aiding radioresistant clones can be tackled. Third is that the micrometastasis anywhere is there, that will be tackled. So exam, they will ask you, why chemo? Why not only radiotherapy? This is a very common question which is asked in the exam. So they will ask you, what is the dose? It's not the original dose. We should give only 40 milligram per square meter. Okay. So started on the first day, as I told you, continued weekly up to 4 to 5 cycles. So they will ask you, see, you may have posting in the radiotherapy unit and you would have never gone and observed. So when you are asked, it's very easy for me to know that they have visited the radiotherapy or they have gone for the, you would be sent to the oncology, you will be going to the cinema theater, and you know that nobody to monitor you. Radiotherapy, oncology, you are sent specialty posting. So it's very easy for me. I will ask you that how many days it is given, which day chemotherapy is given. Small questions, if I ask, they know that, okay, this person has not attended any course. So this is how then you can have like ovary, you can have the cisplatin, paclitaxel regime also can be given in cervix. Okay. So this was the old, I just wanted to show you some pictures. Okay. This is the old radiotherapy EBRT machine, teletherapy machine. Then we came to cobalt-60 teletherapy unit. Now we have gone to the linear accelerator. Everything is fixed. Okay. Linear accelerator. Previously it was 2D planning. Now we have gone to the 3D planning system. You have gone to new terminologies like, see, I told you organ at risk. You want to and doesn't want to have damage, all these things. We have the concept of IMRT and IGRT. IMRT is intensity modulated radiotherapy, and IGRT is image guided radiotherapy. Basically what it is, if you are asked, you should know the full form of it. Everybody should know all these things because all these small concepts. So we are focusing it correctly on to the where we have to give one. So you don't have to see, previously we have point A, point B and all. So point A. So why this is point A and point B and all these things? Radiotherapy, to measure the radiotherapy, this much should be gone. It should, here it is very specific. You go and only where you want. We chart it out in MRI and you go and give where you want. That is what is IMRT and IGRT. This is just to show you that it is nothing to do with gynec. So here you recently I saw advertisements like Manipal Hospital has started cyber knife. At least you should know cyber knife is not a knife, it's a radiotherapy thing. So it is not coming to gynecology, it is mainly in brain tumors and all. Cyber knife is nothing, it's a radiotherapy, cutting knife. It is nothing to do with scissor or knife. So basic things you should understand, that what is the basic concepts. This roadmap and all these things is a radiotherapy point, why chemotherapy came, and you should know the National Cancer Institute has told in February 19, almost 22 years back, it has been told. 22 years back, it was told that concurrent chemo radiation has to be done. So we come to the last part of it. See, last 2-3 photos I will show you. What do you mean by brachytherapy? See, nothing. Brachytherapy is that you are applying intracavitary into the cavity. Okay. There are two ways. If it is extending into the parametrium, we use the, so brachytherapy can be local radiation, can be intracavitary, or it can be interstitial, implants at interstitial. So it consists of positioning designed applicator, sealed radiocell source into the body cavity, close to the tissue. So you are close into your tissue. So and it is left there. Okay. So why then, there is a question, very important question for postgraduate. Why uterine cervix is suited? So many times when you remove the uterus, do surgery and send to radiotherapy, oh, you could have kept it, it would have been easy for us, they say. Why? Why cervix is a very important for brachytherapy, or why in cervix brachytherapy is important? Reason is that there is high tolerance to cervix, uterus and vagina, not like other tissues. It is an accessible organ. You can see and put it inside. Endocervical canal or vaginal vault, if you have done, a suitable vehicle to carry rigid applicators. And application can be used with minor modification in all patients. So the same can be modified and kept in the other patients. So this is how. So then they will ask you, intracavitary, previously Stockholm, Paris, Manchester. Now it has come to Manchester system QB, and Paris system is a late interstitial. So intracavitary systems are 3, interstitial systems are 3. Names were just for a namesake. See, this is the brachytherapy planning and all these things. So we have, if they ask you, you say tandem and ring, tandem and void, tandem and cylinder, and interstitial needles. The last 2 pictures. See, this is how previously it was all separate. Okay, this intracavitary and interstitial. Now you remember this Vienna applicator and Veneza applicator. Please, all postgraduates, see Vienna and Veneza. If you tell the names itself, the examiner knows that you know something. Here it is together, interstitial, see, intracavitary and the interstitial together. In one applicator, it is very suitable. Now coming to the last part of it, see, this is how it is planned and all these things. Last slides of the, when it comes to see, it is now locally advanced. From it has gone to the distant. Distant means our role is very simple. It is cisplatin-based chemotherapy. The role is chemotherapy. Concurrent CCRT can be also given in some cases, positive para-aortic node. See, when you put a scope or when you do a surgery, okay, you have done. First thing what you do, you have to see everything. See, you are having a para-aortic node, and first thing what you do, take out the node, wait. Usually what I used to do is I go and have a tea or a coffee and I come back. By the time the frozen session, the node is positive, means I close it and send the patient for CCRT. So where you have to show up, you should know. And another very important thing, see, many people all around, see, I'm not blaming surgeons and all. See, I had seen cases done by surgeons. See, even if whoever does the case, we don't mind, even a surgeon or anybody wants to do, but they should know how to examine. See, I have 3 months back, I was called suddenly to another hospital, patient is bleeding. Surgeon was doing a laparoscopy TLH. TLH was the surgery. I went there, it was full bleeding from the sides, broad ligament, it was fully bleeding. Then I went down, just put a speculum, there's a cauliflower growth in the cervix. Then I asked the surgeon that you did not see. Surgeon told that usually we don't see. Only scan shows something we see. So this is, so basically, whenever you are going to do, please all of you, just by scan, you have to, Clinical examination is what is the most important. So clinical examination, clinical examination, clinical examination. A role will never go, especially in Ca.Cervix. I don't know about ovary. Even there is role, but Ca.Cervix clinical examination is a must. Otherwise, you land. So this type you land up. The best option is that if you are expert, you go inside, do a parametrectomy and lymphadenectomy, and then only manage the patient. But many times we cannot do. So we give post-operative radiotherapy. They say that better send the patient for CCRT. So if you are, it's not an easy surgery to do on another second laparotomy. So when your exam, they are asked in this common question: hysterectomy was done, cervical malignancy is the report. What will you do? So you can say that either I can go about parametrectomy and lymphadenectomy, complete it and manage it. Otherwise, I will directly send the patient for CCRT. Now coming to the last part, last slide of the day. See, you should all know how do you follow up these patients. Okay. So it's the same. You should understand that the mean recurrence is the first 3 years. Okay. If the patient has crossed 5 years, then you don't have to do anything. And one more thing, every monthly, every 3 monthly you have to call. Then every 6 monthly until 5 years. Then annually for lifetime. This is what you do. See, here, don't do anything and any imaging techniques. Clinical examination, and a Walt smear. This is what you do. So, and unnecessary things should not be done. So, unless if the patient had a pelvic lymph node involvement and all these things in the previous thing, that is the only time when you do. So, only time when you send for this. Once it is 5 years has crossed, then it is national guidelines, routine guidelines is enough. Last slide. What are the complications of this is just to tell you that early the radiation field you should know. The fields according to I told you OAR. So patient will have cramps, diarrhea, fatigue, because radiotherapy is over also. Patient is our patient. Patient will come to you. So you should know this. What are the things? So chronic bowel irritation, chronic bladder irritation, sexual dysfunction, over all these things will be there. So we should know all these things and what are the complications of radiotherapy. So we complete. So what we learned today, all the postgraduate, what we learned today, we learned the FIGO 2019 update. What are things, what are the changes that occur? Only 3 changes you remember. In the first, you removed that 7 millimeter. That lateral extension is not there, only depth is there. Okay. Then you told that B is classified into B1, B2, B3. That B2 has come. Then we told 2A2, that is more than 4 centimeter. And the third part is that the pelvic lymph nodes are removed. That is over. So easy, everybody should know that in a classification like early stage and locally advanced and distant metastasis. So early stage, I told you the most important thing is that 1B3, that is more than 4 centimeters, no surgery can be done, even if it is 1B3. So it has to go to the bulky disease, then entirely different. There it is CCRT. So only the early stage surgery in, if you, and locally advanced stage CCRT. In one word, it is finished. So which surgery, what surgery, everything I have told. And please remember that Coromora class, postgraduate, not for others. Please remember that Coromora classification and AB type A, B, C, D and levels. Please remember that is what. Then I told you, see, you should know nothing. Radius CCRT, why chemo, cisplatin, why it is added, how it is added. And we told last that I gave you an insight. 80 has to be there, 50 teletherapy, 30 brachytherapy, teletherapy itself. I told you. How it is given. Okay, 25 see, it's 25 fractions you have to give, 25 fractions. Okay, when you give 25 fractions, you give two guys per day, so it becomes 50. So that is how you give. Then I told you how the importance of post treatment follow-up. I told you then patients coming with, that is a common thing. We get patients coming with hysterectomy pathology report telling that I did hysterectomy, it is a Ca.Cervix, what to do. But these type of things should not happen. Clinical examination, that is the most important thing. We also told about trachealectomy, which we told, okay. And the importance of LVSI, please remember, LVSI negative, then only you can leave the patient. It is positive, then you have to do all these things, okay. And finally, we told you how to follow up these patients. Okay, first 2 years, 3 monthly, and then 6 monthly for 5 years, and lifelong 5 yearly follow-up. And also we told clinical examination is important. And finally, 1 or 2 complications of radiotherapy you should know. And please remember that words in radiotherapy, because you should not be ignorant in front of others. As gynecologists, we cannot say that we don't know anything about radiotherapy. That is why purposefully I collected these photos and put, at least you should know cyber knife, all these things. You hear something is IMRT, IGRT, why it is there, what is it, OAR. You go to a radiotherapy department, they will be using 100 times. So you will be sitting in a radiotherapy, that means a oncology meeting. You will see what is this OAR that you are reluctant to ask. You are senior and you cannot ask also. OAR is organ at risk, nothing. Bladder and bowel and bladder, rectum and bowel. That is what is OAR. So everything now say that OAR, they say. So all these things we understood. Anyway, thank you. I think that I have taken 5-10 minutes more than what was allotted me. Sorry, Hiramat sir. Because I wanted to finish it due to excitement. I went over the time.
No, not at all.
Yes,
Vidya, your chat box has got only 3
thank
questions. Vidya.
Yes.
Can you ask those questions to him?
Thank you, Ashwath. It was really very elaborate and very academically oriented, and for the consultant also it was very nice lecture you gave. Okay, and there are many appreciating messages in the chat box. Only one question I see in the chat box is they want to know about the anatomy about the ureteric tunnel.
Ureteric tunnel dissection during hysterectomy. Radical.
Okay, radical hysterectomy. See.
Yeah.
You have, when you start the dissection, see, when you do radical hysterectomy, the most important, our aim is to have that ureter in the. So first we isolate the ureter. From there we start dissecting. Initially we divide that paravesical space and pararectal spaces. So when you go down after the crossing of the uterine artery, see, you clamp the uterine artery, you change the side, then it goes into the ureteric tunnel, which is in the cardinal ligament. So this is just that ureteric tunnel is the place where the bleeding occurs the maximum. So you want to how to dissect it. So you take it. You say what you do is that in an open surgery, what you do is that you take 2 arteries and keep over the ureter, you dissect. You go to the ureteric tunnel, you just hold it on both sides and cut in the center. Then automatically the ureter will come out like this. See, we have to be very careful. The ureteric injury most frequent is there. And one more thing I will tell you, the bleeding. So there are many veins are there. Uterine veins come there. These veins are the dangerous. So vein starts bleeding. So this is how you dissect it out. So only the guide you have is the ureter. You have to be very careful during that area. That is the 2 things which you have to be careful. One, injuring the ureter. You cannot go deep. And the most important is a bleeding. So you may have to be careful. Then you will not have bleeding. That is what is ureteric tunnel dissection.
Yeah. And there is a second question from Dr. Dwarkanath. What are the fertility preserving surgeries in gynecological malignancy, especially in Ca.Cervix? What all investigations will do?
See, there are only 2 fertility preserving surgeries which I have explained. One is conization, other is trachealectomy. Okay. Conization, as I told you, just once more I can tell, I have explained, but once more I will tell. It's a conization. When you do, it can be when you cut the corn. Okay, you cut it corn. You have to take the full squamocolumnar junction out of it. Then you see for the margins. Okay. If the margins are not involved, first thing is if the margins are not involved, that is, and it is 1A1. And you also see for LBSI. LBSI is also negative. It's enough. You have done it. And then you can then put all these cases, you put a cerclage. And as a patient can become pregnant, nothing will happen. It will go forward. But when it is little advanced, either LBSI is positive or you automatically it is more than 5 millimeter depth. Then up to 1B1 only fertility sparing can be done. There we go for trachealectomy, where you remove the cervix and parametrium, and the lymph nodes are removed laparoscopically. So this is, and I told you, so the stages in which it can be 2 initial, 1A1, and without LBSA, conization is enough. Corn biopsy, conization can be done for other also, but you have to look for the margins. Okay. LBSI is positive, you have to do radical trachealectomy. Once radical trachealectomy is done, you have to put a cervical stitch also. So these are the indications, and I've told you less than 2 centimeter, length of the cervix should be 4 centimeter, like that. It has to be that criteria should be maintained. Patient should be fertility needed, patient male partner should be properly assessed, and all these things, and less than 335, it should not be too much obese. The BMI should be less than 35. That all that criteria should be satisfied to do a fertility preserving surgery.
Yeah, and one more question is how you will manage infertility and pregnancy with Ca.Cervix.
See, I will tell you three situations. I will tell you when I was working in, so it will become very clear for all of you. See, a patient in very early stage came, very early stage. See, one common principle everybody should understand is that malignancy should be considered first. Okay, not pregnancy. Whenever pregnancy, if malignancy is there, malignancy should be managed. So I tell you, a 28 weeks pregnancy came with vaginal bleeding. Actually, they told it will be IPH. Speculum was done. We saw in the, not I, my madam, and there in cancer research, it saw a mass over the cervix. Small biopsy was taken. It came as Ca.Cervix. Here it is crossed 28 weeks. Steroid was given. You know what was done? Cesarean was done. Baby was taken out, and on table, Vertime hysterectomy was done. Okay, all of you understood? Okay.
Yes.
Now I will tell you another situation, small situation. 30 weeks patient came with such a tumor. It was advanced. That means it was 3B. Advanced referred case, it was 3B, 30 weeks. There what was done was that cesarean was done, baby was taken out, and the uterus was closed, and the patient was sent for CCRT. Okay, madam?
Okay.
Now I will tell you another simple situation. 12 weeks coming with the advanced stage. 12 weeks. Okay. There what was done was that in situ hysterectomy was done. See, we did not remove the fetus or anything. Keeping it, Vertime hysterectomy was done. Okay, madam? Okay.
Yes.
So these are the different situations. And one more thing. Till carcinoma in situ, patient can have vaginal delivery. So we only in invasive malignancy, all these things are done. Carcinoma in situ, till we can continue the pregnancy and patient can have a vaginal delivery. So that confusion is over. Okay.
Thank you.
Vidya,
And
can
most
you-
of the cases are squamous cell carcinomas. Some of the cases are adenocarcinomas. So any difference?
Difference is
in
there.
the management?
Squamous cell carcinoma. See, here what we say is that in squamous cell carcinoma, what we say is that you don't have to remove the ovaries. Okay. In adenocarcinomas, you have to remove the ovaries. Understood? So adeno can be, it can, so ovarian conservation, that's the most important. Another thing, younger age group, this adenocarcinomas are more common in younger age group, and it considered to be little aggressive. So the all adenocarcinomas, we do lymphadenectomy also. Even if it is an early stage also, we have to go for aggressive management than a squamous cell carcinoma. Okay, these are the two things which, so ovarian conservation and early, see, young age patient comes, we conserve the ovaries. We don't remove the ovaries for squamous cell carcinoma. What we do is we Vertime hysterectomy, we put it into the paracolic gutters away from the radiation field. So you mark and put it above the radiation field. Even patient is an advanced stage. Imagine you want to send the patient for radiotherapy. It's a 32-year-old patient. What we don't have to remove the ovary. Laparoscopically, we take the transfix the ovaries up below the diaphragm. Actually, here upward into the anterior abdominal wall, we suture it and keep it. So away from the radiation, whatever you do, it should be away from the radiation field. Otherwise, no use. You conserve the ovary, you give radiation, it will be going. So this is another ovarian conservation pattern.
Dr. Vidya, can you go for closure?
Yeah, sir. Sir, your concluding remarks.
Before concluding remark, one thing today what I would like to appreciate is 2 days back I gave a message to our another group, Kasoga Medical College HOD group, and I made an appeal that this topic which we are going to select it is a very much oriented for the postgraduate teaching, and I request you to encourage your postgraduates to join. Today I am very happy that quite a good number of heads of the Department of Medical College have joined and quite a good number of young postgraduates have joined. I can see their name on the screen. Wholeheartedly, I would like to thank them very much for motivating their postgraduates, because we are taking so much pain to bring the speakers. I think it should reach to the target. Our today's target was we wanted to reach to the postgraduates. I think first of all, I would like to thank all our HODs, and I would also like to thank all our office bearers and also the committee chairpersons. Dr. Ashwath, it was an excellent. Now, why I am telling you it is an excellent, because I am in the medical college for last 40 years. And we are seeing carcinoma cervix day in and day out. That too, if you are working in a government medical college, your bulk of the case is Ca.Cervix. And ultimately, you end up with death. these patients are going to die over a period of time. And there are a large number of diseases where you will see your patients will not die. For example, I operated a case 38 years back, C endometrium. I saw her last week walking on a road. Now, this generally we don't see on a Ca.Cervix because it is so aggressive, particularly if it is a clear cell carcinoma or if it is a squamous cell carcinoma, and a lot of changes have taken place. But you have beautifully restricted yourself to the topic what has, because Ca.Cervix is such a huge topic. You can speak for hours together, but you have restricted to your topic so beautifully, and you have clarified our postgraduates so well regarding the classification. When I was taking my PG examination, a month before I had put up all the classifications on the wall of my room. I used to by heart every day these classifications. And now looking at these classifications, so much changes. But you have given a reasonable reasons why the change has occurred. I think that will make them to understand. Just to ask them to by heart the classification, it will not help. But reasonably telling why the change has occurred, and from 7 mm to 4 mm, and what other changes have taken, very beautifully you have cleared all their doubts. I feel all the doubts in the staging has been cleared. And role of the X-ray, radio, the CT, MRI, how limited role they have. And another very important thing which you have stressed is clinical examination. You have told one case like that, there are hundreds of cases. They don't even put a speculum and look at the cervix, what is the size of the growth. And they just remove the growth and close. And large number of surgeons are operating without any basic oncology training. As you have rightly told that if you want to operate a case of malignancy, please operate provided you are trained in that field. During our time, there was no training program. Now there are a lot of training programs are there. Lot of centers are giving the program. At least go for a 6 months to 1 year so that you will not do injustice to the patient. See, once we do a injustice with our primary surgery, nothing will help them because the disease will be spreading. It go in the lymphovascular area and it will advance. So I think a clinical thorough examination, taking time to stage it properly. I think proper staging is the first rule in the proper management, which you have rightly stressed very well. And you have covered all the surgeries for conservative, surgeries for radical, and pre-Vardhyan's era, post-Vardhyan's era, you used to stress so much. Now that has gone because things have changed a lot and the guidelines have come. I think Japanese have done a lot of work in this, in the management of Ca.Cervix, comparing to all other countries. And the NCCN also, you have given a beautiful guideline. Pelvic lymph node, beautiful classification. You said 1, 2, 3, 4, 5. I think that's a fantastic. Once you have got that clearance, that which are the nodes which I should tackle, I think it will give a lot of. And LACC trial you have mentioned, which was really chemoradiation, role of chemoradiation. Definitely chemoradiation has helped because the chemo will sensitize the tissue and the radiation will definitely help. Otherwise, it was only a radiation. So radiation is there in all the stages, but selectively surgery has to be given, which you have made very, very clear. So thank you very much, Dr. Ashwath, for beautifully covering the topic. I was very sure that you will do very well because I know you very well. And I thought that this should help our postgraduates and our consultant also, because as a consultant, we have to give the justice to the community. And once we do a wrong diagnosis or misdiagnosis, within few months to 1 year, the patient will go to the next stage. And once they go to the next stage, whatever you do, their 5-year survival rate is going to be reduced. I think very first visit, when you identify the disease, when you diagnose the disease, the best management protocol has to be planned as per the whatever as on today, the literature is available. You have covered all the literature which is available on Ca.Cervix management. Thank you very much for wonderful talk. And I think everybody has enjoyed. Murli, Mantala, everybody has enjoyed.
Yes,
You
yes.
have so
Many
well.
congratulations, Ashwath. It was very comprehensive and exhaustive. Very good. You didn't leave anything, and it was so wonderful.
Everything you have
Thank you,
covered.
sir. Thank you.
Lastly, I would like to thank the MCure. You know, MCure are our very best academic partners Today, nobody is attending. He said, sir, you will do justice to our program and our company will not come with the scene at all. And they are continuously supporting us. And you know that they have got wonderful molecules, over for XT, right and left we have used, and we have identified how best it is when compared to others. Cost may not be the reason, but wonderful results. And now they have come with Oro for FCM, which we are doing extensively, we are using. And even in pregnancy also it has been approved. I think it will give a very good result. And PAS MF is there another molecule, which we are very, very happy. And very recently they have come with the Didrofem. I was one of the scientific committee group when there was, for a long time, there was only one company which was supplying this dydrogesterone. Today, Didrofem is another one which has got equally good results, reasonably cost-wise also. I request all of you to use their molecules which are really internationally standard, and I thank them for having supported the scientific program. So I would like to thank each and everyone. Now I request our treasurer, Dr. Durgadas, to thank one and all. And I saw him, he was nodding his head so well that he was appreciating your talk from the beginning. Dr. Durgadas.
Yes. Good evening, everybody. Thank you for giving me this opportunity. Dr. Ashwath, congratulations for the excellent talk. You are a combination of very good PG teacher, excellent lab surgeon, and also a dedicated clinician.
Camera ultagide, sir.
We are not able to see you, Dr. Durgadas.
Nagaratnama madam has come today.
Durgadas sir, camera ultagide.
It has crossed 75, Ashwath Kumar, today.
Thank you.
Yeah.
Postgraduates have
So
joined.
many.
We are very happy.
And there are few questions that they can ask you directly on your phone.
Okay,
or
okay.
email.
They
You
can
share your
email.
mail
Durgadas has
ID.
come.
You see in the chat box. Yeah.
I will send email.
Sari hoytu sir ಈಗ continue ಮಾಡಿ.
Sir, okay, thank you. Dr. Ashwath, you are
Yes.
still as a very good teacher was very evident today from your today's talk. It was had very clear message. It was as if we were sitting in a classroom and listening to your lectures. Ashwath, we never forget your role as a quizmaster in Foxy. Every on those days, every quiz, Ashwath was there on the stage, and it was we are sitting in the sides and we are enjoying your quizmaster. One thing out of the box I want to quote here. It was a great achievement of Kerala obstetricians in reducing MMR to 30 in 2017 and 19. Lots of appreciations were pouring into the Kerala group. It was a fantastic achievement.
Thank you, sir.
You are all
by Dr. Paili.
one of the pillars in building this achievement. Congratulations,
It's
Ashwath.
mainly we are work under Dr. Paili.
Paili sir, I know I got this news from Paili sir, and I know you are one of the pillar in building this achievement. So I wanted to congratulate you on this behalf. So KCOG is immensely thanking you, Dr. Ashwath, for finding time even in the midst of your consultation hour, and also KCOG is showing its gratitude for the regards you are having on us. Thank you, Ashwath.
Thank you, sir. Thank you so much. I also enjoyed the talk. Thank you.
I thank our chief patron, Dr. M.G. Hiremat, and the convener of today's program, Dr. Vidya Tobi, our incoming KCOG president-elect. I also thank our president, Dr. Basavaraj Surgeon, his last webinar today, and it has ended with Ashwath's talk. Yeah. I thank our secretary, our secretary, Dr. Bharati Rajshekar, our joint secretary, Dr. Manjula Patil. I also thank KCOG chairman, Dr. Muralidhar Pai, Dean, Dr. Hema Divakar, secretary of KCOG, Dr. Vidya Bhatt. I thank all the delegates who have joined today. I also thank the sponsor of today's evening, MCure Pharma. I also thank the supporting staff, Mr. John and Arun. Thank you, everybody.
Thank you, Durgadas. Thank you.
Thank you.
Now I can see a lot of names here who have joined in this program. I think today we are very happy that so many the people have joined for the academic program in spite of having physical. See, when the corona was almost about to end, I thought these programs may not survive. I feel it is going to survive in a way the people are getting involved. And as rightly told by Ashwath, just I was having coffee while listening to Ashwath, because it is so comfortable. I am in my house on my table, and at a evening where we have planned, I think almost for last 1 year, 2 days in a week, I have closed my practice. I am not going in the evening. And now I have become addict now. I can't go on Thursday because my patients knows that I am not coming on Thursday. Even if I go also, hardly there will be 3-4 people. So I said, let me continue with Thursday absenteeism so that it will be a relaxation. So I once again thank Dr. Nagaratnama is here, Ashwin is here, Nandini is here, Blanche, Asmiya, Soumya, Bhavya, Rekha Upadhyay madam,
my postgraduates
our
maximum
HOD,
are there, all.
Bharti,
Yeah.
Lakshmi, Krishnananda Malle as usual. He is there for all our programs and always he is there. And today we have got many. I request all of you to please spare Thursdays and practice only for 5 days in a week, because once the doctor, the series said, I know him very well for last 50 years. And what he was telling me, Hiremat, after reaching certain age and certain time, you stop your practice for few days for 2 reasons. One, your physical body will not cope up with you what you practice for 7 days. Number 2, you must encourage your youngsters. If you are available, everybody will want to come to you. A day you say that you are not available, the emergency people will go to your juniors in a way that you are supporting your juniors and you are helping your juniors. I remember these are the words he used to tell, and he used to practice. Dr. Siri Seth was practicing only 4 days in a week. I know, almost for last 20 years. He was available only 4 days in Mumbai. 1 day was reserved for Rotary. 1 day was reserved for Foxy. 1 day was reserved for family. Such great ideas and thinking. And he used to say that you will not lose your practice. Your practice will improve. You become a non-available person. More people will come to you. I think I realized it really. What he was telling by practice, it was really a good one. I think we can make academics along with other commitment also, provided we plan. I personally feel time management is very important. If all of us manage our time, we can do everything. We can do everything perfectly. Only thing is we should time and manage our time. With these few words, today I say goodbye to all of you, especially to Dr. Ashwath, who is my very good friend, and he has come as a rescue to today me, because 3 days back I was not having a speaker. Then suddenly I was rolling my Facebook, and in the Facebook, Ashwath face came. Then let me ask Ashwath whether he is free on Thursday. When I gave ring to him, he said, "I'm happy to join. Give me 4 hours time. I am in OPD. My mobile is not working properly. I go home and I will contact you. Then we will decide about the subject." So nicely he has agreed, and he has given such a beautiful talk. I think it will go a long way. Yes. Anybody would like to say 1 or 2 minutes? We have 5 minutes time is there. I think Ashwath can say some few words other than academics. Because he enjoys in Foxy so much. And
the thing is that, sir, your idea of this, how did you get this idea? Well, one personal question: how did you get this idea of this college? Because it was such a wonderful idea.
I think Vidya is the right person who has understood me. She said, "How can you get such ideas?" So I thought, because see, we have to go a little higher level. Now, when you form a college, the quality will go. And when you form a university, your quality will. For example, our KLE University, they have grown so much big. Now I am a part of KLE University. I have joined as a principal of a new medical college. How beautifully they planned. I owe this to Dr. Prabhakar Kore, who is a very great visionary. And he brought this medical college in 1 year. Imagine, 1 year back, there was nothing, even a building. Then we took a primary school building, high school building, and the college building. And today we have got 150 admissions neat. And I thought that we have become stagnant. KCOG has become stagnant because 30 years. something new we should do.
You should
So
be
we
doing.
thought there should be, and Murli supported me, and Murli helped me. Then we thought Hema, being so much internationally having contacts, she can be the best dean. So we thought and started. Wonderfully, it is doing.
Excellent,
And we
sir.
have
An
given,
excellent idea. That is what
like
Yes,
FICOG, we have given last time 15 seniors
seniors,
honorary fellowship under FKCOG. So we have honored all those who have the pillars of the KCOG for last 30 years. So in due course, we are going to have the other people
exams
also
and
will get
yeah, you can, sir.
fellowship.
You can have some exams and all.
Yeah, exams, board exams, and
Board
all these
exams
things
and
we
all.
are. It is in the pipeline. I'm
So
happy
many
that you
things
are
can be
also.
done.
I'm happy that when you become president, you may also plan like this.
No, 100%, sir. All I'll see.
Yes,
This is
from Kerala.
this is one plan in my mind, madam. Vidya,
Yeah.
madam, it
Yeah,
is
yeah.
my plan in my
Nice,
mind,
nice, very
and
nice.
I
It
was
will help a
asking all
lot. I
this.
tell you, it will help a lot.
That I will take all guidance from you all people, so that it has to go out now. It has to be in all states to do that. Then only the development and academics will develop like anything.
And Ashwath, no speaker has refused our request for your kind information, including the international speakers. When
You
you
are
said that
calling
you are
me,
going
who
to,
will
you are going
refuse,
to
sir?
address
You are calling
the
me, who will refuse?
Karnataka College of Obstetrician and Gynecologist, they were so happy and they expressed that it is really a great thing and they thought it is an honor. We are not
Real,
pressurizing them
sir.
to be
Real,
speaker.
when you are called from a college, that is
Yeah.
the difference is there.
Yes.
So, see, when we go for other, it's nothing to do with other talks. Many
Yes.
times it has a political side of it. Once it
Yes.
comes to a college, it's entirely
Yes.
different. It's serious. That's an academic is what it matters. I was sitting and adding all because I was knowing that PGs will be there all this way, and it should be beneficial. It should be a talk which should be beneficial for everybody. It should be authentic. That means you should have studies which are particular. All these things I was very particular that I know false information should be there. Everything should be clear. That was I also prepared 3 days only you give me,
Yeah.
but I enjoyed preparing for it. 3 days, last 3 days.
Thank you very much. Thank you. Namaste to everybody.
Thank you, sir. Thank
Good
you, sir.
night.
Good night. Good night.
Enjoy
all.
Holi tomorrow. Enjoy Holi color and enjoy life.
Good night.
Thank you, Manjula.
Good night. Good night.
Thanks.
Good night.
Good night.
Everyone.